Well, welcome everyone again. I'm pleased to have you with me. As you know, I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma. Coming today, not from Oklahoma, but from the West Coast of the United States. And I'm really pleased to have the opportunity to share with you some interesting cases that have come through our area and to my attention. We have some great students and residents who've helped to locate some of these cases, and sometimes they just come across your desk for routine patient care. Um, I was planning to make the majority of our presentation today on inflammatory diseases, but I just couldn't help wanting to share a particularly interesting case that we came across um, for a couple of reasons. So let's begin with this case. As we do so, however, let me just mention that this is intended to be interactive and to allow you to ask questions. And you can ask questions in one of two ways. You can type them into the chat. You can unmute yourself and raise your voice to ask a question. Or if you prefer, you can ask me offline using my email connectivity, either through the YouTube or through the email at the University of Oklahoma. So here is our case. This is a 44-year-old woman who has a couple of gastric biopsies. I believe she had some mild epigastric pain. And there were, on our routine slides, as you can see here on the right, there were three different levels, 1, 2, and 3. And each of these was fairly similar in size, although the first levels were relatively shallow. And low magnification, I look at this biopsy and I didn't see too much that was of concern to me. So, we looked at this level, and then we looked back here at this level. And, if I was just doing a very low magnification sign out, I might have, made that the end of it. This set of levels sort of got separated a little bit here. Usually I come to high magnification for a couple of reasons. So I'll come down and I'll check to see are there any eosinophils, because I know I can't pick those out really well at low magnification, and I don't see any here. And then I just look to see is there anything else. And I don't spend a lot of time at high magnification, but this is a case that sobers me significantly to that regard, because as you see here, there's something that doesn't belong. And I don't think at routine magnification, other than maybe here at about 10x, would you have seen this. But here they are. As you can see, there's a cluster of cells that have peripheral nuclei sort of compressed against the side of the cell with a sort of central pale eosinophilic to amphiphilic substance that looks a little bit like mucin. Well, these I think are by definition signet ring cells. And so we see those in primarily neoplasia. We look around to see, are there other features of dysplasia now? Are there other areas? We went back to the first level here. And as we look around here, you'll see that we don't see them. So this, I think, underscores two important principles. One is doing sequential levels can be helpful in uncovering unexpected findings. Now, there's one little finding here that begins to make me a little suspect as well, and that is these sort of gobletoid mucin cells here within the mucosa. With signet ring neoplasia, we don't usually see a surface lesion, and we may not see an in situ lesion, but we can occasionally see an in situ type of lesion as a precursor in some settings. And we've done a video on that topic before. Here in our third level, again, we see these cells, but they're very, very few. You know, maybe there's only 20 cells here. So I'm sure you're wondering, you know, the question, how would you sign this out? How was it signed out? Well, this case actually came to my attention, not because it was my case, and I was sobered by that because I'm not sure that I would have seen this. But it came to my attention because the patient came for follow-up and had a repeat sampling. And in that repeat sampling, there were no cells, anything like this. So I went back to this case and looked at it, and to make sure that what they had seen was, in fact, potentially neoplastic signet ring cells. I think these are potentially neoplastic. So what would we do from here? We have a minute area of likely malignant cells. How was this signed out? Well, this was signed out as gastric mucosa with a rare small cluster of signet ring cells. They didn't call it gastric adenocarcinoma poorly differentiated. And I'm not sure that I would do that, but I think these most likely are signet ring cells of a gastric poorly differentiated adenocarcinoma. I don't see many other things that it could be. There's very limited amount of things that we could do with this. I suppose you could do some immunohistochemical staining. You might look at, you know, are these keratin positives? That would be, I think, confirmatory rather than being histiocytes, but they don't have the foamy cytoplasmic character that we might expect with histiocytes. So I think this patient has or had a gastric cancer. I'm not sure that follow-up biopsies were particularly helpful, other than to say there's no visible lesion, and the random biopsies that were done from different areas of the stomach did not have either an in situ or any further evidence of this residual lesion. But the stomach is a vast organ, and small 2 or 3 millimeter biopsies are probably not going to be able to detect this. This may be too small to do genetic testing, but there is one germline test that might be valuable in this situation, and that would be to test the patient to see if they have an underlying germline CDH1 mutation, or to see if there's any family history of gastric or breast cancers. Because as you are aware, the CDH1 mutation, if it's present as a germline mutation, can predispose people to poorly differentiated gastric carcinomas of this type, or lobular carcinomas of the breast, two fairly related types of tumors. So that was the first case I wanted to share with you, and I'll pause this share. You can type in your questions if you have a question or comment on that one, and then we'll go to the next round here in just a minute. I have to get that set of cases pulled up and ready for you. So be thinking about that as we go on here. Okay. All right, we're ready to share again and go forward with some cases. All right. So back to GI biopsies and low power magnification. Get rid of that. There we go. Okay. So low power magnification, looking at this set of colonic biopsies, there are a couple of things that I notice. First off, it looks a little bit blue. And so this is a blue biopsy. Now, that's of course governed by the proportion usually of inflammatory cells in the lamina propria. And that can vary from one area of the colon to another. Typically, in the right colon around the cecum, we tend to have more inflammatory cells than we do in the left colon, in the sigmoid and rectum, and so forth. So that certainly is a consideration. Also note that we have generally parallel glands and crypts. There's not really any distortion or destruction, but it looks like we may have some surface loss or erosion. And maybe even over here, we have a degree of sort of eruptive inflammation. If you can see that here, there's a little bit of surface erosion and this subsurface hyaline change. So this could be an early incipient toxin-related colitis. We don't see withering glands per se. It could be some other sort of change related to that. But this loss of surface epithelium indicates that there's something going on here. And notice also we have a little bit of subsurface fibrin. So I think this is a very early example of a sort of pseudomembranous type colitis. Even though we don't have fully developed pseudomembranes, we did have this one area over here with a very early eruptive appearance here. And this is the pseudomembrane, is this exudate on the surface. So with this type of a sample, I would certainly say, we should do toxin checking. Now, the other possibility is that this is a collagenous colitis, because you'll see we have a pretty prominent hyalinization to the epithelial plate here. And we do have a lot of intraepithelial inflammation here, as well as the damage to the surface epithelium. So a collagenous colitis with secondary superimposed pseudomembranes would also be a possibility. And that may be more likely than a very dramatic toxin-related colitis, because we don't see the withering, destructive appearance in the deeper portions of the glands. So this could be either collagenous colitis with some superimposed inflammatory changes on the surface, or a toxin-related colitis. So that's a nice early example of how I would approach a case like this. I think seeing these multiple pseudomembrane formation type areas does make me concerned about a toxin, and I would certainly recommend that they do evaluation for the Clostridium type B toxin. Of course, other organisms can have that toxin as well if they've exchanged plasmids and so forth. Okay, well, if you have questions, don't hesitate to pause me and stop me there. Of course, with pseudomembranous colitis, with collagenous colitis, one of the tests of some help is the performance of a trichrome stain. This is not the typical stain that we use. We use a Mason's trichrome. This is a Gamori trichrome. But I think here you can also see that there is prominence of the collagenous basal plate that stands out from the other areas and makes this appear more prominent in this situation. All along here. And notice that it spares the crypts. It's just along the basolaminal plate as the area that's most involved. And this can sometimes be fairly thick, up to maybe 5 microns or something like that. But anything that's beyond a micron should be regarded as potentially significant. Now, typically this presents in older women with watery kinds of diarrhea. And of course, that is the classic presentation, but we can see it in other settings as well. This basal collagenous deposition can also on occasion occur in other locations, in the stomach, maybe the small bowel occasionally, but the significance in those locations is a little bit less certain. And it may be associated with some, of course, lymphocytic or other features of microscopic colitis. In general, I don't make this diagnosis if I don't have another finding as well, which is some evidence of surface epithelial damage. Now, you can't appreciate that here because we're just highlighting the basal lamina thickening, but you'd like to see something like we had in the prior slide with either erosion of the surface or active intraepithelial inflammation, distortion of the surface epithelial appearance. All right, well, let's go on to another case. Again, this looks like a blue biopsy. As you can see here, there's a lot of blue to this lesion. And it looks fairly similar to that first case we had. We don't see any pseudomembranes here per se. Here we see a little bit of stuff on the surface, but it's not quite the same as what we were seeing there. Here's the kind of change I was referring to on the surface. You see here there's some loss of the mucin. The nuclei are somewhat distorted and variably located. There just is what I refer to as a disarray to the surface epithelium. The nuclei are scattered of variable size and so forth. And so seeing that with this increase of inflammatory cells here in these random biopsies would, to my mind, make this into the category of microscopic colitis. Now, as you know, that comes in several flavors. There's kind of a lymphocytic colitis where you've got the more prominent lymphocytes throughout the epithelium. And this does have maybe an increase in lymphocytes here in some of the areas of this epithelium. You can see down here, there's more than one lymphocyte nucleus per 5 enterocyte nuclei. Collagenous colitis is the second flavor. And then just a general microscopic colitis where you've got sort of indistinct, not otherwise specified damage to the surface epithelium, some evidence of maybe some increased lamina propria, plasmacytic inflammation, and these other features. Now, these features are not usually evident to the endoscopist, and that's why they do random biopsies, is because they're looking for these kinds of changes. Now, so that would, without any history, this would be diagnosed as microscopic colitis, not otherwise specified. However, this turns out to be a patient who was receiving pembrolizumab, one of the immune checkpoint inhibitors, and therefore this is going to be one of the patterns that can be seen with immune checkpoint inhibitor related colitis. So you see it's a non-distorting colitis, a non-distorting inflammatory pattern with a surface epithelial damage and some increased lamina propria inflammatory cells as we see here. These drug agents can mimic or produce findings that mimic other types of inflammatory disease, which can include ulcerative colitis with crypt abscesses and distortion. But I think more typically, this microscopic colitis type of pattern is what you should expect to see in those patients. And they're usually picked up because after they begin the drug, they begin to have intestinal symptoms, maybe some diarrhea, maybe some cramping, maybe a little blood, those sorts of changes. And that, of course, is treated with significance by the oncologist and sends them for endoscopy. Now, there are certain agents which are more prone to develop this than others. I won't go into that because I don't have to make that choice. But you can see them with virtually any of those immune checkpoint inhibitors. So this is another patient and another pattern. This is, as you can see here, maybe not as blue, and we actually have some pinker areas, a very lost pattern of glands with some sort of dropout here. So we see some normal areas. Here's an abnormal area. Here's a, I don't know, it looks necrotic type of area, maybe an exudate. Here's more of this pattern. And then here's an area that's sort of in between. So let's go and look at this area first. This is the pattern of pseudomembranous type colitis or withering glands, where the glands are all distorted and destroyed, and they hypersecrete a mucin to sort of wash out the toxin or whatever that's annoying them. You get fibrinoid necrosis to the cells and so forth. And it's kind of geographical. This here just is the inflammatory exudate or pseudomembrane, as you can see there. Here we see some hypermucin secretion. Here we see lots of mucin on the surface again. So this is part of this hyperstimulated hypermucinous change. Looking over here, we see more exudate and more of this pattern here with, again, these withering, that's W-I-T-H-E-R-I-N-G, meaning they're shrinking, they're getting smaller sort of appearance, and it's pretty much full thickness. Now, ischemic colitis can also give you that appearance of withering glands and necrotic appearing. Here's an area where we're beginning to get that sort of change, where you see the glands beginning to shrink down, as you see here, getting smaller, normal-sized glands here, smaller glands, withered glands here in this area, and the beginnings of this hypersecretory change. So as I looked at this case, I thought, well, this is a likely either pseudomembranous or ischemic colitis. She was quite an old patient, so I wondered about the possibility of ischemic colitis. Additionally, this was from one of the watershed areas in the distal sigmoid. The distal sigmoid and hepatic flexure are kind of those watershed areas where you're more likely to get flow-related ischemic damage. Here we see more of this pattern of damage. But then it came to our knowledge that this patient was on another targeted therapy for cancer, in her case, a BRAF inhibitor. And I had never seen BRAF inhibitor colitis, so I did a quick check, did some literature searching to see what was reported. And sure enough, many of the changes of ischemic colitis are what are reported with BRAF inhibitor colitis. And so most likely this is ischemic or toxigenic related type of colitis, secondary to the use of a BRAF inhibitor to treat her cancer with BRAF mutation. So those are a couple of caveat sort of mimics of things that can look like ischemic, pseudomembranous, and microscopic colitis that I thought we would put in here at the beginning to just make this very timely. So we'll go on to the next case. This is, again, quite a blue biopsy. We have a lot of blue cells in here. I don't see much in the way of normal mucosa at all. And coming down, we see that there are some residual glands here. They're in variable sizes, a little bit of almost granulation tissue type of appearance here. Here's a destroyed crypt, maybe some food particles. Lots of plasma cells in here. It's difficult to identify landmarks, surface, muscularis, anything of that sort. And here we see rather classical glandular branching and variability, and some evidence of damage. We don't see active crypt destruction per se in the sense of crypt abscesses, but certainly we see features of glandular regeneration and damage, this branching pattern. So that's an indication of chronicity. The dense lymphoplasmacytic infiltrate puts this in the category of chronic colitis. And so this certainly looks to be an inflammatory bowel disease. So next we look to see, kind of how bad is it? How are we going to communicate that degree of severity? Well, we don't see crypt abscesses. That's one marker. We see mostly chronic inflammation rather than very much acute inflammation. We see architectural distortion, and we see probably some degree of ulceration and granulation type tissue in a few of the fragments. So those are all factors that are used in various grading systems. The one that we use in our laboratory is the GIBOS grading system, which qualifies things based on architectural distortion, on the pattern of inflammation that are present, on the presence of crypt abscess, ulceration or fissuring ulcerations, and so forth. Now, I'm not an expert on the application of that system. I've never been trained in it. I've just read the literature and tried to apply it in a general sense. But I think being descriptive about the features that you have can be helpful in the case of inflammatory bowel disease. And so what we see and what we don't see are both important factors. We don't see granulomas here. We don't see a fissuring ulcer, but we do see dense lymphoplasmacytic inflammation. We don't see too much in the way of neutrophils. There's maybe a few in here with this sort of ulcerated area, which we would want to describe. And that can be very useful to the endoscopist to correspond to what they've seen in terms of extent of disease and the kinds of ulcerations and so forth that they may have seen, whether they saw pseudopolyps or those sorts of things. So that's most likely this is ulcerative colitis, depending on the distribution. But it could also be Crohn's disease in some settings if the clinical pathologic correlation is appropriate. And so for that reason, when I sign one of these cases out, I use the more generic term of active chronic colitis, and then I may provide that GIBOS grade and a description of what features we have, GIBOS score, what we have here and what we don't have. The clinician can then, based on what they've seen in terms of distribution, other symptoms and so forth, determine whether that's going to be more likely to be Crohn's disease or ulcerative colitis or indeterminate colitis if they're having difficulty making that distinction. So I thought we'd do a few resection samples, which also show examples of some of the findings that we can see. This gives us a broader range of options. First of all, from low magnification, of course, you see that the inflammation is localized to the mucosa. There's nothing down in the muscularis. There's nothing in the adventitia. Well, maybe we have a few little lymphoid aggregates here. So maybe we can't totally exclude Crohn's disease because we do have a little bit of perivascular type of inflammation here in the adventitia, which we should not see in general in ulcerative colitis. And it looks as though we may be in the terminal ileum. We certainly have germinal centers, and we have here a nice appearance of distorted glands with active crypt abscesses, as you can see here, this nice luminal appearance with lots of neutrophils involved in the lesion here. So involvement of the terminal ileum with crypt abscesses and distortion, a modicum of deeper inflammation, and this traces of adventitial inflammation probably put this into the category of Crohn's disease. But there are certainly cases where you can get refluxing backwash, as it's called, back into the terminal ileum that can cause a degree of damage in the ileum. And so clinically, this was felt. Oops, what happened here? Let's just come back in, see if we can reload. Okay, there we go. I'm not sure what that little hiccup was. That certainly would be possible as well. Now, the time to make the distinction between Crohn's disease and ulcerative colitis is generally at resection. If you get a resection sample of colon and you can't decide, then you got to make sure that you've examined it completely and can come up with something that looks that's going to at least give you a lean. Now, I do know that there are experts who will come to the conclusion that it's an indeterminate colitis, indeterminate chronic colitis, meaning that they can't decide between Crohn's disease and ulcerative colitis. But it is helpful to make that distinction if you can, because that will make some differences in follow-up. So here again, we see mostly confined to the mucosa type of inflammation. We see some preserved glands here. We do see a little bit of fissuring here, some germinal centers, and severe ulceration. We don't see much here in the way of transmural inflammation. So that, again, may suggest ulcerative colitis. Though, again, down here, you see there is a little bit out here that suggests there may have been some antigen leakage and some other things going on down here that may have jazzed this up a little bit. So one of the other features that I wanted to highlight here is what I would sort of term an indistinct muscularis mucosa. So we don't see the typical single band of muscularis mucosa, but instead we see all of this. Is this collagenous or is this smooth muscle proliferation? Well, one of the features that you can get with inflammatory bowel disease is a marked hypertrophy of the muscularis mucosa. And that can sometimes take this pattern of a very broad, indistinct zone of muscularis. Here is very edematous and so forth. Part of the challenge here is you have lost some of your mucosal motility, and that damage contributes to the diarrhea, contributes to the pain, and so forth. So this loss of muscularis or this hypertrophy, alternating hypertrophy of muscularis is one of the features that can be possible. And again, I think most of this is probably collagenous tissue rather than muscularis. We'll see some other examples where it's actually a very dense band, but usually that's in a more healed state where there's been some healing over time and the muscularis has responded in that way. So let's go on and do another case here. And here again, we see this prominence of this eosinophilic band here. So here the mucosal damage is not as severe. We see this sort of villus pattern change. And here I think you can appreciate that this is muscularis mucosa that's become quite hypertrophic. And it really jumps out to you at low magnification, as you can see here. Again, our inflammation is primarily limited to the mucosa. And in this case, we don't see a lot of crypt abscesses. We do see this secondary change, the smooth muscle hyperplasia, and maybe a few areas. Certainly we have chronicity with the variable architectural changes of pseudovillus type of change, and maybe a little bit of intraepithelial inflammation, a lot of eosinophils and plasma cells. That is also a marker of the inflammatory changes. So not as dense, a variable pattern of chronic inflammation, but a secondary pronounced smooth muscle hyperplasia of the muscularis mucosa. All right, let's see if we can get to some other cases here. One other active UC case here with a very dense area of ulceration and granulation type tissue. A little tiny bit of thickening of the muscularis mucosa there. And you can see how it's pulling muscularis up here and making this more hypertrophic. Here it almost looks as though we have sort of virussite type of changes. These smudged nuclei and variable pleomorphism to some of these nuclei. So sometimes you do have to exclude viral enteropathies, but those typically don't give you this pattern of dense inflammation. So this is maybe a little pseudopolyp, as you can see in that area there. And then here's an area that's relatively spared. We have, again, the altered architecture and a little bit of thickening. Now, the more common situation that we see in our practice in terms of follow-up on these patients, particularly those that are receiving some of the targeted therapies, is that their mucosal appearance will revert virtually to normal and will become, with effective treatment, indistinguishable from normal. And so the only thing that keys us to the fact that they've had inflammatory bowel, and that's why they're being followed, is the history. And so it's certainly not impossible to see patients who've been treated for a period of time who have regressed completely. And you're not going to see much in the way of sort of quiescent chronic colitis. On the other hand, if I see areas where, maybe the crypts don't reach all the way to the muscularis, where there's a bit of branching like this in some of the crypts, and they're not very parallel, this sort of appearance, if this were present on a biopsy, I would say this is a quiescent chronic colitis. And that corresponds to a very low Gibo score, 0.3 or something of that sort, that would be indicative that there's not much in the way of active inflammation. Okay, well, here we'll move on to Crohn's disease. And again, we're in the small bowel. And I think you can see here at low magnification, quite prominent adventitial inflammation, deep submucosal inflammation, and then some evidence of surface distortion. It's not particularly great here. As we look at these glands, There is a little bit of sort of hyperplasia. There is some architectural alteration here. And note again, the muscularis mucosa is getting stretched and pulled and becoming a little bit hyperplastic, hypertrophic. So this is muscularis mucosa, and it's far beyond the normal thickness, and some of it's getting pulled up into the mucosa here with variable ulceration and inflammatory change. Again, you can see how that muscularis becomes hypertrophic. Now, I talk a lot about this muscularis mucosa change because that's certainly not something that I think is covered in very many textbooks. Certainly was not covered in medical school, for me at least. Yeah, dear. I apologize. I seem to be having a little hiccup here in the connection. Let's go on to the next case here. We didn't see any granulomas in that particular sample. Here's another setting that's been termed Crohn's disease, but here we can see very little in the way of deep involvement. And it looks a lot like that ulcerative colitis case. We don't see much in the way of deep inflammation. We do see vascular congestion. We do see some areas of dense lymphoid inflammation. Certainly we see shortened glands here, a lot of lymphoid aggregate type of change, not much in the way of active crypt abscess formation. So this, I think, was a case where the diagnostic changes of Crohn's disease were present in other sections rather than this section per se. However, we can look down here and see if these are just myenteric plexus. Not really seeing much in the way of adventitia here. So we'll go on one more case here. Oh, I think this is from the same patient. All right, here's another nice example of Crohn's disease. You can see transmural inflammation. And here we begin to see some pseudopolyp formation and a degree of sort of fissuring type of ulceration. Here's a fissure right here where it's the ulcer debris is coming down nearly to the muscularis mucosa, and sometimes it can get all the way to the muscularis propria. We can see nice glandular distortion, variability. We see ulcer debris. So there's active ulceration and the regenerative architectural changes. Again, we see the chronicity here with the thickening of the muscularis mucosa. Now, obviously, these cases have been treated, and so you've got a variation in terms of treatment response and disease recrudescence, if you will, that can make the appearance in a resected specimen sometimes difficult to evaluate. You always want to look into your little lymphoid aggregates to see if you've got evidence of granulomatous inflammation. Here's another area where you might say, is this a little granuloma? And sure enough, here we see the presence of a little granuloma. Now, while that's not totally specific for Crohn's disease, it is helpful in terms of making the nice predilection towards Crohn's disease to find areas of granulomatous inflammation. And in fact, you can find granulomas at virtually any level. You can find them up in the mucosa. This might be one here. I don't know. Maybe that's not. You can find them in the submucosa. You can find them in the adventitial inflammation. If you look here, I think you'll see we have one here. Nice granuloma there. And in fact, you can even find them in the draining lymph nodes on these patients as well. So granulomas non-infectious, but certainly a hallmark for many cases of Crohn's disease. It's not 100%, but a significant portion will have that, and it's helpful when they're present. All right, well, we're just about to the end of the hour. I think we've got one more active Crohn's disease case here that we'll go through. And this again shows a pseudopolyp, where you see an area ulceration, and here's a nice fissuring ulcer. As you see, it just sort of dives. It's a deep canyon going down in here. You see the necro-inflammatory debris here. It's in this case, it's reaching the muscularis propria and forming that fissure. And of course, this is the predisposing feature that enables or tends Crohn's disease to be more likely to form fistulae. Fistulae are decidedly rare with ulcerative colitis, not impossible, but much more uncommon. So two nice features of Crohn's disease here, the pseudopolyp, a relatively spared mucosa with ulceration on each side, and the nice fissuring ulceration that could predispose to developing a fistula. The other feature, I think, just to recall, that can help or helps to promote and encourage the formation of fistula is the adventitial inflammation. So if you get the adventitial inflammation forming a little bit of stickiness here, that can lead to fibrous adhesions between loops of bowel. That changes the motility and then may lead to further possibility for fissuring ulceration, and the fissuring ulceration with connectivity to an adjacent loop of bowel, then of course can lead to the presence of a fistula. So it's 8 o'clock here. I see we have a question in the chat. Question, very good question. With the fluoride inflammatory reaction, do we need to be concerned about lymphoma? And if so, what features do we need to look for? So lymphoma is an uncommon entity in the bowel, but certainly a dense lymphatic or lymphoid inflammation that was distorting the mucosa and so forth and filling the submucosa could be an indicator for lymphoma. I don't think it usually enters into the differential with inflammatory bowel disease per se, but it certainly can produce some symptoms that would be similar. In general, as we've seen here, many of these inflammatory bowel disease lesions will have small germinal centers in some of these lymphoid follicles, sorts of things, so these things. Or you may find the granulomas that we saw earlier. But I think generally a diffuse, distorting type of pattern that seems to be more focused in the lamina propria would be more likely to be lymphoma than inflammatory bowel disease. So those hallmarks would be useful. Typically, you would not find crypt abscesses or active mucosal ulceration with crypt abscesses with lymphoma. You certainly would not see the smooth muscle hyperplasia that we've described here in several of these samples. So very good question. Thank you for asking that. Well, with that, we'll stop the share, and thank you so much for being with us. If you have follow-up questions, don't hesitate to email me or bring those up. Or if you have great cases that you want to share, I appreciate the chance to look at those as well, because we always are learning from what we see. That's how we learn in pathology, is case-based learning from the cases we see. Well, thank you, everyone. It's been a pleasure to be with you. And so until next month, hope you have a great time. Also, just as a heads up, next month we will have a guest professor, and I believe we'll be talking about some GU lesions, if I'm remembering correctly. So hope that you'll join me then in mid-September.